Okay, folks, let me get something a little bit nicer. Uh, a little bit brighter. Dr. Cabullo. Okay, well,
Yes, Dr. John, how are you?
how you doing, Dr. Cabullo?
Good, good.
Hey, would you like to moderate today?
It's okay, no problem.
Okay, I'll introduce you and then you take it away, okay?
It's okay.
Okay, okay, let me. How you been? You working a lot, Dr. Cabullo?
Sorry?
You working a lot?
Yes, we are working.
Oh, okay.
Yeah.
Let me put something more professional.
How is the weather in Miami?
It's rainy, it's stormy. It's like the rainy season, you know?
Oh, okay.
So it's not so sunny. It's sunny in the morning, but then it clouds up and rains in the afternoon. But it's not a bad rain. It's, but it's certainly not as sunny as it usually is.
Okay.
Yeah, we had a good Asian Congress neurosurgery webinar. Oh, Yuha is speaking on Friday, Dr. Cabullo.
On Friday?
Friday, right, at 9 o'clock China time, but that in in the you're in Mozambique now, right?
Zimbabwe.
Zimbabwe. I think it's around 6 o'clock your time.
It's okay. I'll be online.
You know the difference between China. What is China like 3.5 hours ahead of you? Or?
Yeah, let me check.
Yeah. It's one of those. It's doable, but Yuha is getting a lot of Chinese neurosurgeons watching, which he wanted.
Sure. You say it will be 9 a.m. in China?
No, 9 p.m. 9 p.m.
Oh, 9 p.m.
So it should be 6 p.m. or it's 5:30 p.m. in Zimbabwe.
Yeah, it will be 3 p.m.
Oh, 6 hours difference. Wow.
Yes, 6 hours.
Yeah. Oh, I didn't know it was that long. Wow, 6 hours. That's yeah, and he's been hosted by Ben Wu. You know Ben, the Moya.
Yes.
He is going to translate Yuha's presentation into Chinese at the same time that Yuha's, like he's going to be off camera listening and translating into another program that's going to be televised to China, to Chinese neurosurgeons.
Okay.
So Yuha, and Yuha likes that. Because he's been trying to reach the China neurosurgeons, but you know, as you know, there's a problem of translation. Then you went there, right? Didn't you go there at that conference?
To China? No, I didn't go.
Oh, you never made it?
Yeah, no.
Okay, your visa, yeah, I have visa. I couldn't get my visa in time.
Yeah, I remember, I think that's the time you went to Portugal, isn't it?
Yeah. Well, I wanted to go to China originally, but it just took me 2 months. And then at the end, I couldn't really, I had to either pay for the plane ticket or, you know, and I didn't know if I was going to get my visa. So I had to cancel.
Yeah, I had also the same issue. I didn't get my visa.
Oh, you didn't end up not? Yeah, we were going to room together. Maybe, remember I got a room and everything.
Yeah, sure.
Yeah. So of course I had to cancel that. Oh, okay. Where's Dr. Sabaya? Okay, let me get, I don't know. Oh. I'm betting, oh, okay, Dr. Abraham said he's coming in 1 minute. You know how temperamental these big neurosurgeons are.
Hi, John. How are you?
Hey, how you doing, Rupesh? How you been?
I'm doing good.
Well, I'm glad you're here because I know there's going to be some activity.
Yeah, I hope so too.
Well, that's what this is for. It's for interaction, you know?
Exactly.
And I hope people take advantage of it.
Mhm.
Where are you at, Rupesh?
I'm actually in Nepal right now.
Oh, okay. Are you in Bharatnagar or
I'm in Kathmandu. I'm in Kathmandu, but you told me something about Dr. Hype a few weeks back.
I was in Bharatnagar for 3 months.
Yeah, I know that. That was
Oh,
like
okay. You do
3-4
that?
years ago.
Yeah, it went well. I met a lot of neurosurgeons. I met IPE is great for networking with the community of neurosurgery. I mean, he knows them all.
He
And a
does.
lot of it, he had a conference there. So I met Dr. Kato, Vlad, Dr. Peeve, I met a lot of.
So all of them were
neurosurgeons.
here.
You know, a lot of them came, and it was great to meet them. And I still remember them. It's been 3 years. And we just started a webcast with Dr. Kato a couple of weeks ago. The
Dr. Yafo.
ACNS, and it's going great.
Yeah, okay. Actually, I joined it last week also, and Dr. Lawton was there.
Oh yeah. We have people drop by that.
Dr. Ibrahim is here.
Hey, Dr. Abraham, how you doing?
Hello.
You saw Dr. Abraham, you there?
Yeah, I'm here.
Yeah, you saw me promoting it, right? Did you see it all over the place, right?
Yeah, yes.
It's all over the place. You can't get away from it.
No.
Okay, so you ready almost to start? Yeah, you are speaking again Friday, Dr. Abraham, if you want to come.
Yes, yes. Not Friday, actually, next Wednesday.
It's at 9 o'clock China time, so I think in Jordan that would probably be around 5 o'clock. I'm not sure what time.
Which one you are talking about?
Yeah. You'll be getting, you'll see the advertisement and with the link and everything.
Sure.
Okay, you ready to start?
I'm ready.
Okay, let me, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami. This is Dr. John Bennett, home of Neurosurgical TV. Today we have the pleasure of hosting the Jordan Neurosurgery Grand Rounds from Oman with Dr. Abraham Sabeya. And I'll turn it right over to Dr. Sabeya. Welcome, Dr. Sabeya. It's all yours.
Thank you very much indeed. Okay, so here you are. Good day, good night, good afternoon, good morning, whatever you are. I'm Abraham Sabeya from Amman, Jordan, and we are transmitting live from Amman, from the Farah Medical Campus. Today I'm going to talk about clinoidal meningioma, that is the anterior clinoid meningiomas. Some people call it sphenocavernos. And as usual, I will discuss this from the clinical, radiological, operative, pathological, and pathological correlation. No doubt that the anterior clinoid meningiomas in that area are formidable lesions, and they are very challenging lesions. So let's talk about the anterior clinoid process. We don't only need to know the anatomy of the anterior clinoid process, but to know the variations of anatomy in that area. And that applies to anywhere you would operate upon. So the sphenoid bone, the body, the medial lateral pterygoid plates, the greater wing, and the lizard wing. People think of the lizard wing as really a little thing. It is a large thing. And in that wing, lizard wing, there is the optic canal, and there is the anterior clinoid process. So here are anterior clinoid here. All this is the lizard wing of sphenoid. So it's a rather big area, actually. Again here, the body of the sphenoid, which contains the sella and the sphenoid sinus, the greater wing of the sphenoid, foramen ovale, and the spinosum here. And you can see that this structure is really big. The anterior clinoid is just the medial tip, medial part of this great structure, which is the lizard wing of sphenoid, which contains the optic canal. So here we are, the body of the sphenoid, the anterior clinoid, the optic canal, and sometimes you get this middle clinoid. Of course, this is the dorsum celli and the posterior clinoid. This is foramen lacerum. So the body contains the sella on top of the body, the sphenoid sinus inside. This is the sphenoid sinus, and this is the anterior clinoid, and this is the optic strut separating the optic canal from the superior orbital fissure. So anterior clinoid is really big, and some people even classify it, because it's big, into a tip, a head, a body, and a base. Look at that. This paper, a very beautiful paper by Hannesimi Juha from Finland, and they describe this: the tip, the head, body, and the base of the sphenoid. So we have to start thinking of the lizard sphenoid as something less or lesser. It is really big. So here you can see the tip, again, the same classification: tip, the head, body, and the base. Again, here, sometimes you will see this anatomy in good shape. Here we have removed the anterior clinoid so that you can see the superior orbital fissure. And what separates the optic canal from the superior orbital fissure is the optic strut. So this is oblique view to show you the optic canal and the optic strut, separating the optic canal from the superior orbital fissure. Same thing here. The anterior clinoid, the optic canal, the optic strut. As I said, sometimes there is actually calcification here, and it forms a ring, and that's called another middle clinoid ligament or middle clinoid foramen, as it were. So not only that we need to know the anatomy of the anterior clinoid, the normal anatomy, but we need to know the abnormal anatomy. And this is reported to be there about 10 to 15% of population. So here you are, circling the carotid is this middle clinoid process, as in here, again as in here too. So we need to know what are the structures that are related to the anterior clinoid. It's so important. It's related to so many important neurovascular structures, including oculomotor nerve, which the clinoid is actually on the superior aspect. The carotid is the inferior aspect of the anterior clinoid. Optic nerve is in the superior medial aspect. Let's see that. So here we are. If we look at the anterior clinoid, the third nerve in its segments going into the superior orbital fissure passes underneath the anterior clinoid. So the anterior clinoid is superior to the third nerve. Again, here it's looking from behind the posterior clinoid, the anterior clinoid, the third nerve in its various segments, dividing here into two parts in the superior orbital fissure. But as it goes into the roof of the cavernous sinus, it is underneath the anterior clinoid process. Visual view of a cadaveric specimen of the optic nerve, nerve chiasm, and lamina terminalis is here, posterior clinoid is here, carotid coming out as the intra-subarachnoid segment of the carotid artery, dividing into its branches and so on. And this is the posterior communicating going to the junction between P1 and P2, the posterior cerebral. Again, the third nerve related to the anterior clinoid. Carotid passing underneath it also. So this is the anterior clinoid, and this is the carotid, and this is the ophthalmic artery. Ophthalmic artery arises from the dorsal aspect, dorsal or dorsomedial aspect of the carotid artery. We need to know all these information if we want to operate on an anterior clinoid meningioma here. This beautiful view from the book of Vinco Dullens. Vinco Dullens came to Jordan. He gave many cadaveric lessons and structures. You can see the various parts of the carotid and the relationship of the carotid to the anterior clinoid. Beautiful view here. This is the paraclival segment. This is the cavernous segment, and this is the clinoid segment, which is not intradural, not extradural, and then it comes out as the intracranial subarachnoid segment. So anterior clinoid is so much related to the carotid artery, and you can see here the bone and the carotid artery related to it. Also, we need to know the dural rings that are surrounding the carotid artery in relation to the ophthalmic artery. Ophthalmic artery arises from the carotid after a sort of more intracranial, more subarachnoid space away from the dural rings, whether the upper ring or the lower ring. So here we are showing you the rings, as it were, lower ring and upper ring, or proximal ring and distal ring, just the same. Here again, we have removed it. It is a structure that is there. Some people wrote some papers that do they exist or not, they do, but sometimes not in a form of a ring that we know. Again here, olfactory tract, optic nerve, the falciform ligament here, which could be small, few millimeters, it could be 1 full centimeter. So the young neurosurgeon resident should be aware of this fact. Here is the optic nerve, the carotid, and you can see the ophthalmic artery arises in the subarachnoid space. The upper ring is here, and it goes into the optic canal. Of course, it crosses inside and then goes above the optic nerve to go medially. Again, pituitary gland and the sella, and this is the carotid, and this is the ophthalmic artery. Here is of course, is the anterior clinoid. If you drill out the anterior clinoid, then you will come into the roof of the sinus. You will see the clinoidal part of the carotid. You will see both the distal ring and the proximal ring. And usually there is a venous tributaries there that can cause some bleeding when you are doing the drilling. Of course, you can see here, sorry. You can see here the optic strut, as I said, separating us from the superior orbital fissure. Relationship of the ophthalmic artery, usually it comes distal to the upper ring, sometimes through the upper ring, sometimes actually it does not go at all into the optic canal, it goes into the superior orbital fissure. Again, knowledge of the anatomy, knowledge of the abnormal anatomy and the anatomical variations that are there. So here we are, the optic nerve, the carotid, the anterior clinoid process covering both the third nerve and the carotid artery. Again, reminder of the falciform ligament, which could be 1 to 2 millimeter or 1 full centimeter. Anterior clinoid intact, anterior clinoid removed. So the distal ring is here, the proximal ring is here. Relationship of the anterior clinoid to optic nerve, to the carotid, to the third nerve. Here the anterior clinoid has been removed. So anterior clinoid really is a very important landmark in the skull and in the skull base. And if you're doing any surgery there, you must have a full knowledge of the normal anatomy and the abnormal anatomy. Again, you are there near the cavernous sinus, so you need to know all the triangles of the cavernous sinus that started, as you know, by Parkinson triangle, and then we have full 12 triangles now. One thing you would face when you do the anterior clinoid meningioma is the sylvian fissure and the sylvian fissure veins. And here is a group of veins draining into the saphenoparietal sinus. These you would face in any anterior clinoid meningiomas. So you need to know the anatomy, you need to know how to preserve them, you need to know how to open the sylvian fissure, going from for the frontal and not for the temporal and so on, and the zigzag of the temporal, zigzag of these sylvian fissures. A beautiful paper from Japan about this relationship of these veins in the sylvian fissure, superficial middle cerebral vein going into the sphenoparietal sinus. Again, this beautiful paper also from Japan showing a very beautiful venous relationship. So if I have a meningioma here and the superficial middle cerebral vein is coming here to go into the sphenoparietal sinus, this actually meningioma may close the sphenoparietal sinus. So the drainage will be up towards the superior sagittal sinus. Here, it did not, it was closed completely, but the drainage is down through the base of the temporal lobe. Here, you can see that it's going into the cavernous sinus. So various types that you need to study on venogram before you embark on doing any surgery at the anterior clinoid. Let's see how it looks radiologically. This is the usual picture of the image of the anterior clinoid process. But sometimes it gets aerated, and the aeration is through the optic strut. So the communication between the sphenoid sinus and the anterior clinoid comes through the optic strut. As such, optic strut and coming here from the sphenoid sinus, like this. This is called type 1. It is larger ones, type 2. And type 3 is really extensive. It could be unilateral, it could be bilateral. So these are the variations here. It's a unilateral aeration of the anterior clinoid because part of surgery for anterior clinoid meningioma is to drill the anterior clinoid. And if you are not aware that this aeration, and then you will end with CSF leak, meningitis, and others. You can see here the bilateral aeration. So there is the essence of the optic strut through which the air comes from the sphenoid sinus into the anterior clinoid. Same thing here, it's bilateral. And you can see the effect on the optic canal. So we describe the anterior clinoid as anatomy. Let's see about the clinoidal meningiomas, which, as I said, sometimes they are described as spheno-cavernous meningiomas. Basically, by definition, anterior clinoid meningiomas arising from the vicinity of the anterior clinoid process, but they may extend medially, laterally, anteriorly, superiorly to various parts. If we want to discuss the anterior clinoidal meningioma, we should exclude those meningiomas coming from other areas like planum sphenoidale or tuberculum ocelli or others. But remember that if the clinoidal meningioma grows to a larger size, then the exact origin is difficult to determine. And you would speak about, is this a cavernous sinus meningioma or this is anterior clinoidal meningioma? People solve that problem. They say if more than two-thirds of the tumor is extra cavernous, most likely this is clinoidal. This is a beautiful paper by John Chu from New York, 2004, describing this as clinoidocavernous, while this as spheno-cavernous, of course with overlap. So you can see that it is sometimes difficult to differentiate this from that. Is this a cavernous or is this anterior clinoid? Nevertheless, you need to know the anatomy, you need to know how to operate upon these structures. Sam al-Mifti from Little Rock, and now he is in Harvard, described this paper back in 1990, describing that we have 3 types of clinoidal meningioma depending on where exactly they are arising. Remember, we said anterior clinoid is a very large structure. It is not a small area. So this description and classification is real. Type 1, which is this one, which is just overlying where the carotid artery is as it comes out, is the most difficult because there is definitely infiltration, there is definitely a close relationship between the artery and the meningioma. Type 2 is easier because you are not in touch with the carotid artery. Type 3 is also easier than this. Of course, they are not easy, but they are easier than this. So the most difficult one is this one, related to the carotid. This is related to the lateral aspect of the clinoid, and this is exactly over the optic canal. So this is what Sam al-Mifti described. Type 1, this is the optic nerve. The anterior clinoid is here, but medial to the anterior clinoid, the tumor is in touch with the carotid artery. So it is surrounding it. You may not find a good plane of cleavage, and you sometimes have to accept defeat that you would leave a remnant there. Type 2, you moved out, you moved to the lateral aspect of the clinoid, so you may find a good plane of cleavage, as in here. Compare this with this. There is a plane of cleavage here, there is arachnoid. While in the third type, which is overlying the optic canal, it's rather easier than the others, but maybe it will press on the optic nerve, and this type usually does not attain large size because it will cause visual manifestations, and people would go to doctors for examination. This beautiful paper again from China, anterior clinoidal meningioma, the relationship with the meninges, the various parts of the clinoid. Remember, we are having or dealing with a large structure. It's called lizard wing, but it is large structure. So various parts, 1, 2, 3, and 4. Type 1 of Sam al-Mifti is arising from here. Type 2 is arising from here. And type 3 is arising from here, and so on. So this is a close look to see that the most difficult part, the most difficult clinoidal meningioma is this one. Here they have classified it into 4 types, which is okay, it's the same thing. Type 1, but type 2 they have classified it into type 2A and 2B, not much of a difference. Basically the same like with Sam al-Mifti. But again, the description is beautiful. Type 1. type 2A, 2B. As you can see here, this is the anterior clinoid and it's going into the cavernous sinus. Type 3, going medially, and type 4 going both medially and laterally as such. The relationship of this anterior clinoidal meningioma is massive with much of the neurovascular structures, and that depends on the increase in size and which direction they would grow. So here, this is type 3 of Osama Nifty sitting on top of the optic canal, infiltrating the canal, causing visual symptoms, so they don't attain large size like the other types. So type 3 does not attain large size usually. There is optic canal involvement with these cases. This is optic nerve, and the anterior clinoid is here. You can see that it is growing into the optic canal. Again, we are seeing this paper describing the high incidence of optic canal involvement, as in here, going into the optic canal. You can actually see the optic canal involvement on MRI. And this is a beautiful view, T2, where you can see here the optic nerve. This is normal optic nerve with the subarachnoid space around it, CSF around it here. You don't see all of CSF, so the optic canal is involved. Where does the blood supply come from to these anterior clinoidal meningioma? Classically, people would teach you that it's coming from the meningio-orbital artery, middle meningeal artery, posterior ethmoidal in particular, which is a branch of the ophthalmic, as you know, or directly from the ophthalmic artery. But few people would describe these twigs from the bifurcation of the internal carotid artery. Like this, optic nerve, here is the chiasm. You can see the carotid artery dividing into A1 and M1, and this is a twig coming here from the bifurcation going to the dura of the anterior clinoid. So if you have an anterior clinoidal meningioma, this could be a very important blood supply, or as in this case, or coming from the carotid artery directly from the posterior communicating, and so on. So they have really extensive blood supply. This paper from Michael McDermott, and you know Michael is a meningioma man. He described this paper in journal Neurosurgery 2016, trying to show you the blood supply of these meningiomas, anterior clinoidal meningiomas, or tuberculum celli meningioma, and using the technique that he used in the aneurysm to see the blood supply coming to these meningiomas. CT angio would be useful and helpful to see the ramification of the carotid artery and the blood supply and so on. So CT angio is very helpful. Anterior clinoidal meningioma with this CT angio and conventional angio. You can see the blush, and you can see where the blush coming from, so that you would know which is the main feeders, and sometimes you may need to do embolization. I already do that, but sometimes I needed to. As I said, this is the paper which I described before regarding the venous drainage of the Sylvian veins in these anterior clinoidal meningiomas. Can they be associated with others? Yes, here in this particular paper from Pakistan, the association of the anterior clinoid with an aneurysm.
بحكي اليوم الانترنت زفت. بحضر محاضرة.
Also bilateral intracranial aneurysms here in relation to the anterior clinoidal meningioma. So meningiomas, aneurysms could be associated, cortical meningiomas associated with basal meningiomas, and so on. Once you see a clinoidal meningioma being small or large, you have a good differential diagnosis to make. This could be hemangiopericytoma, which is very much related to the meningioma, but it's a different entity now. Chondrosarcoma, look at this, it looks very much like a meningioma, so don't be misled. osteosarcoma, metastasis, coming exactly where the sphenoid wing meningiomas are, giant cell tumor, angiofibroma, lymphoma. Lymphoma is a forgotten disease. We have to remember it all the time. Multiple myeloma, paraganglioma, fibrous dysplasia, anaplastic fibrosarcoma, granuloma, Wagner. So differential diagnosis is wide and you have to keep your eyes open. How do they present? As I said, most of the time they present with headaches and visual. These are the main manifestations. Visual is more in type 3, which is sitting on top of the optic canal, headaches in 3 times. Again, the presentation depends on the extension. You may get proptosis, you may get cranial nerves if the cavernous sinus is involved. You may get epilepsy if the temporal lobe is involved. You may get also midbrain pushing on the crus, getting hemiparesis. What is the main treatment? Microsurgery is the main upfront treatment of these meningiomas. Because of the tumor biology, benign or malignant, and the inherent cytotoxic limitations of radiant chemotherapy, surgery is superior and better for all tumors from scalp to toe. And who said that? My friend Atul Gul. It's a very clear statement that surgery comes first. And I add that meningioma surgery in this particular region is challenging. It is a highly technical job. So what approach do you do? Fronto-orbital, fronto-orbitozygomatic, standard terional, extended terional, anterior temporal, pretemporal, and so on. It depends on the size and extension of the tumor. By the way, anterior clinoidectomy has been described first time back in 1968 by late Professor Charles Drake from Canada, and he used this for ophthalmic aneurysm. And then came Professor Yazapil back in 1977, where he added the intradural drilling of the anterior clinoid, and the 1985 Vinko Dollens described the extradural drilling of the anterior clinoidectomy. So this is something that is well established in the neurosurgical practice. This paper, again here by Michael Sigru and Michael McDermott, both are meningioma. I mean, I think Michael Sigru moved now from New York, from San Francisco back to join two in Canada and in Australia, and they described both this paper, meningiomas of anterior clinoid process. Is it wise to drill out the optic canal? The answer is yes. And they showed this beautiful picture where they are drilling here the anterior clinoid and opening the optic canal, taking this one from the roof of the optic canal, the borders of the, this is the nerve in the canal, and these are the borders here. The same thing here, the optic nerve in the subarachnoid space going into the canal. So you may do minimal clinoidectomy, you may do partial clinoidectomy, you may do total clinoidectomy depending on your case. And you may use the sonopet, you may use a drill, electrical drill, or we use the microroger. And this is a picture to show you the removal of the anterior clinoidectomy here in this case. Here is it intact, and here it has been removed. So this is total anterior clinoidectomy. Here you have also, when you do that, you have to remember the, as I said, the vascular relationship and the encasement. Usually this is called Bermuda Triangle. This is rightly so, described rightly so by Daniel Barrow and his group in Pittsburgh. And you can see that this is really important to know the grades of the involvement and encasement of these vessels. If you face a case like this, where it is totally encased and there is narrowing of the vessels, then you have to accept defeat, that you cannot remove all the tumor. If you look at the literature and see what is the extent of gross total resection in the papers published, ranges between 43 to 91. It can never be 100%. You can never speak about Simpson grade 1 excision in this area. The same thing like you don't speak about Simpson grade 1 in petroclival meningiomas, for example. And the recurrence, therefore, is rather high, 4 to 26%. I mean, this is the across the board of the papers published. I choose to make this table. I did it myself. Looked at the papers published, Al-Mifti back in 92. He reported 24 patients. He had 2 mortality, and this is a gross total resection, which is grade 1 to 2. Gould reported 60 cases back in 2000, and he had 3 mortalities, and he achieved gross total resection in 42. But I wanted to say that this is a major challenging surgery, and you may find that you have a mortality and you accept that you cannot do a gross total resection in all cases. A very nice paper, I read it with the enjoyment. Surgical tips for this clinoidal meningioma, which, as I said, is just like the clinoidal meningioma. And also this paper from Russia. And reading actually the referee sort of comments on this paper is very, very refreshing that not only this is done in Burdenko Institute, it's done across Russia, where a very high standard of neurosurgical practice is done. And I look with admiration and respect to Professor Konovalov at Burdenko Institute. They mentioned the Kaplan-Meier for the, as you know, for the, which is better in terms of the progression-free survival, and they conclude that there was no significant difference between total removal, subtotal removal, or with adjuvant treatment. So sometimes you have to stop. If you can remove, go ahead. If you can't, you stop. And here, this paper also from Japan about early optic nerve decompression. When you are doing this, which is a very important part of surgery, the drilling of the anterior clinoid, the opening of the optic canal is an inherent part of this surgery. And this again paper by Juha Hernishimi from Finland. As I said, he is now situated and placed in practicing in China, showing that he can do this anterior clinoidal meningioma via lateral supraorbital approach. This again, very beautiful paper by my great friend, Felix Szymanski from Hadassah, describing his experience in these large clinoidal meningiomas. Again, this is a man to respect. He wrote so many papers on the cavernous sinus, medial wall, lateral wall, roof, and he is an authority in that area. So he's describing his series of large clinoidal meningiomas. So they can be very large. And when you see something like this, you cannot swear whether it started at the anterior clinoid and went to the cavernous sinus or the other way around. Is there a place for endoscopy? Endoscopy, as I said, I keep saying, in the hands of endoscopists lies the future of neurosurgery. Endoscopists have been doing a great job for these tuberculum cell meningiomas. But as far as the anterior clinoidal meningioma, very few papers have been published. This is one of them, published recently from Boston, USA, about the use of the endoscope for removal of anterior clinoidal meningioma. There are so many things to discuss in this part. Difficulty of drilling the optic canal 360 degrees. As I said, this is well established. Indonesian transnasal approach for clinoidal meningioma, and so on. Radiosurgery, is there a place? Not upfront, but for those residual cases or recurrent cases. And this is a paper from Istanbul about gamma knife for these clinoidal meningioma on 61 consecutive cases, a big series really, treating these primarily and secondarily. I would not go personally for gamma knife for anterior clinoidal meningiomas I would refer my patient if there is a recurrence or a residual that has grown in spite of the period of observation. Let me now speak about my series. I was lucky, I got about 60 cases. I've lost follow-up on 18 of them, so I'm reporting the ones that I really have a good follow-up on them, which is minimum of 2 years. Between the year 90 to 2018, I leave always 2 years, because I would not include the case that I have done middle of 2018 now. I need to have at least 2 years to report it. This is a very peculiar case. This is a lady who comes to me from United Arab Emirates. She came with a headache, no visual symptoms. And look at this, soft part, solid part involving the anterior clinoid, carotid is in the middle of everything. Look at this. And examining her, she had no neurological deficits. I said, well, maybe we have to go for surgery to prevent ophthalmological problems. She refused, and she said, even if I get blind, I accept it. Believe you me, I've been following this lady for the last 10 years, and there has been no change in the size or configuration of this meningioma. So 42 cases, of course, females more than males, peak age 40 to 50, mean age 45. Symptoms of manifestations they presented with visual dysfunction, papillary edema, headaches, cognitive problems, seizures, hemiparesis. For all patients, we do full ophthalmological assessment, including visual acuity, fields, color vision, fundoscopy, optic nerve OCT, and we look for exophthalmos. So visual fields, and we use the German score for the visual fields, the visual acuity and the visual field. We combine them together to give us a score, and we do this before surgery and after surgery. Optic OCT to see whether there is any atrophy of the optic nerve. Of course, this is fundoscopy, and sometimes we resort to doing visual evoked responses like this patient of mine. We do psychological testing. I do psychological assessment, and that is in particular Karnofsky Performance Scale for all my patients going through cranial surgery. For me, this is a very important topic. Let me show you the images of my cases. So I'm not going to show you any image which is outside my field. If anything comes up, I will point it out to you. CT, look how important it is to show you the enlargement of the anterior clinoid. And look at here, the optic nerve is being compressed completely. Here, aeration of the anterior clinoid. You can see here various anterior clinoid processes in various cases of mine. So CT is very important. I always insist on having CT. You can see the general information and the specific information about the anterior clinoid process. Angiogram, whether it is MRA, MRV, whether it is CT angio or conventional angiogram is important. So we insist on doing MRA, MRV for all patients. It is part and parcel of the MRI. So when I speak MRI, I mean MRI, MRA, MRV. We do angiography of various parts, and we are interested in seeing the ophthalmic artery, which is usually the main feeder for these anterior clinoid meningiomas, from posterior clinoid, directly from the ophthalmic artery, from the superior hypophyseal artery, and so on. Venogram is important. Here we see the tumor sort of going venous return into the cavernous sinus. Here is the superior petrosal sinus. MRI, and I will show you the MRI of my cases. This is the collection I have. As I said, I have 60 cases. The ones I operated and followed up is 42 cases. So this is some of these cases. Some of them small, some of them large. I just go through them for your interest. Various shapes, various locations. sometimes associated with severe edema. You can see from our eye, you can see the vascular relationship. So what approaches did I use in these cases, 42 cases? Pterional mainly with its modification, 27 cases, fronto-orbital, and 15 cases. This is this is the approach of pterional. This is how you approach it and how you see the structures. And here in this particular case, it was engulfing the carotid artery, the anterior cerebral, middle cerebral artery, but you could find a good plane of cleavage and dissect it completely. Optic nerve, carotid artery, anterior cerebral, middle cerebral. How much did we achieve? Simpson 1 to 2, 22 out of 42. Simpson grade 3 and 4 together are 20. We followed them for a long period of time, 24 months, which is minimum, up to 127, average of 64. And we found that there was residual on the MRI, which we do the very next morning of the surgery. The very next morning, we don't delay it. We could see a residual in 20 patients. As I said, you have to accept defeat in these cases. What would we do? What did we do when we had these residual? We observe. If they grow, we may go for surgery again or gamma knife. So as people think of me as an anti-gamma knife, I'm not. I am anti-abuse of gamma knife. I believe in gamma knife is a good tool, but it has to be used properly and should be not left in the hands of mediocre surgeons. In 22 cases, we had no residual. It was free, and we have done radical excision in Simpson grade 1 to 2. Again, we followed them up, and we found progression. We found recurrence, in 4. And again,
أنينا بالغلط جايبين لي إياها والثانية
when we found this progression or recurrence, again, you can resort to surgery or gamma knife. I will allude to this later on. I show you some cases. What about visual outcome? Improved in 26 of the cases. Static did not change in 14, and that's because there is long period of time where the pressure was on the optic nerve, and it got worse in 2 cases. Did I have any mortality? Luckily, fortunately, I didn't. Morbidity, like the others, CSF leak in 4, wound infection, epilepsy, pyramidal signs, dysphagia, ptosis, and cognitive functions. One of the complications was CSF leak and meningitis occurred because we did not pay attention. We did not recognize that we have entered posterior ethmoidal air cells as we were drilling the anterior clinoid. However, this was corrected. We did put a drain. It did not improve, so I went in and repaired it, and the patient is doing well. We published our work about the predictive markers for meningioma grading, myself and my colleague Hassam Abu Farsakh from the First Medical Lab here in Jordan. And we published this in the American Pathology Academy. We looked at last consecutive 244 meningiomas and looked at them from various points. Regarding age, we found that the high grade comes in younger age, which is bad. This has not been reported before. If we look at the gender, we know females are more than males. Again, in grade 3, it was more in males than in females, 6 to 5. Atypia was more, of course, in the grade 3. Brain invasion was more in grade 3. Bone invasion was more in grade 3. And the necrosis and the percentage of necrosis was more, of course, in grade 3. This goes with the general literature, stream of literature, but the 2 points that I mentioned, that the younger age are going with the high grade and the males are of the high grade. These are 2 not been reported before. Mitotic count, of course, is large in the grade 3. P53, as you can see here, P53 in this range is in grade 1 and 2. It is less in grade 3. So the higher the P53, the better. And the higher the P63 is better. When it's low, you see it in the high grades. Progesterone, again, when it is high, it's good. When it is low, it is bad. Ki-67, as you know, is more in the third time. So this paper has been published in the American Journal of Pathology. Let me show you some of the illustrative cases of mine, and then we go for the some of the videos. This 56-year-old female patient with this clinoidal meningioma before and after surgery. This 70-year-old female patient, there's no place here for gamma knife. This has to be drilled really. And one of the things that one can do is this Fiesta sequence where you can see the optic nerve and its length and where the meningioma is. So we did the surgery. This is before and this is after. This lady from Iraq, 55-year-old female lady with this. This was associated with the most extensive edema I have seen. I was worried that this may tend to be malignant. It was grade 1 actually. But it was associated with extensive edema. Again, we followed her up for many years and she's doing well. This 52-year-old lady, again from Libya, with this tumor, anterior clinoid, and the long follow-up, and the lady herself. Again, this patient from Jordan with this tumor here and post-op. This very giant tumor, which when I saw, my heart sunk. Actually, I did not want to. I wanted her to go somewhere else, but she insisted, and I had to go. And it was really frightening to see this picture. We went in, and this is immediate post-operative. This is the one about a week later, and this is a long follow-up. Now, you may argue there is a remnant there, but we are following that up, and nothing is happening. Again, this lady with this clinoidal meningioma before and after surgery. This 63-year-old lady with this giant anterior clinoidal meningioma. And this lady from Jordan with this huge giant anterior clinoidal meningioma. And this where you will face the veins. I will show you the video. To face the vein in front of you before you get into the tumor is something frightening. Again, this anterior clinoidal meningioma before and after surgery, and this 55-year-old male patient, 70-year-old female patient with this extensive tumor before surgery and after. And again, this here, again, you see the vessels encasement. You may say, oh, this is inoperable. Don't say that, because once you go in, you will discover whether it is operable or inoperable, whether you can dissect it off the vessels or not. We left remnant, and we've been following that for so many years without any change. Let me now share with you the recurrent cases. This Jordanian lady, 45-year-old female patient with this meningioma, which I operated, and we left just a remnant there. And it recurred, of course. She refused any further treatment. This is a Jordanian patient of mine, 38-year-old male patient with this extensive meningioma. Again, I had to leave this residual on the lateral surface of the cavernous sinus. He's the one who developed ptosis, but that was transient. It disappeared in 2 months' time. So it recurred, and we have to give gamma knife. So again, I'm not an anti-gamma person. I am against the abuse of the gamma knife. I am with the use, the good use of gamma knife, against the abuse of gamma knife. This very nice lady, she's a professor of English language. At that time, she was 47, coming with this. Again, look at the bifurcation here. Look at vessels going everywhere. And I really wanted to do embolization, which really helped me a lot. This is the post-operative. You may argue that we left a piece there, but she did well. And then she developed recurrence. We gave gamma knife. It did not respond. It grew again, and patient refused any further treatment. So let me show you now some of the videos, and I would go through them very quickly. With each video, which is last maybe less than a minute, we just show a certain point so that we will learn from the video as much as we can. This is the lady which I showed you, the sitting in front of you with the vessel, with the veins of the Sylvian veins going into the sphenoparietal sinus here. Again, being patient, going between the blood vessels, the arteries, branches of the middle cerebral, and the veins, branches of the superficial middle cerebral going into sphenoparietal sinus. Just being patient, it will pay you. It is a good dividend. So here we are separating the vessels from the surface of the tumor. And here, this is the middle cerebral artery going here into the carotid. Again, here, finding a good plane of cleavage. So don't be disheartened when you see they are attached. You have to differentiate between blood vessels going to the tumor and those who are not going to the tumor. Here, I'm seeing the carotid. Still, the tumor is attached to it. I'm opening the carotid cistern. As you can see that we are working between the veins and the arteries. Just being patient and devascularizing the tumor, you can get rid of it completely. So here we are taking this in between these branches of middle cerebral artery and of the middle cerebral superficial veins. Here we are taking it from the lateral wall of the cavernous sinus. So the more you try, the better. When you remove as much as you can, that will be fine. And this is the beautiful picture of the optic nerve and the structures. Okay. This is just from the beginning. You have to drill the greater wing of sphenoid until you reach to the anterior clinoid, and you can see the periorbita here. So drilling of the internal clinoid extradurally, like described by Vinco Dolenz. This is temporal, this is frontal. Here, you have done the drilling here, and you have opened the optic canal, removing the edge, the lateral edge of the optic canal, freeing the optic canal completely, opening the falciform ligament, and also the dura, which is within the optic canal. Again, drilling of the bone involved. And here I just want to show you that we're drilling on the right side. And once you drill here, having drilled the anterior clinoid and open the optic canal, look at the distance here. You can see a good distance. And you can see here immediately the ophthalmic artery. If you're not careful, and you may damage that, but you need to remove the tumor from inside. Now going to the other side here, I will show you that there is a big chunk of the tumor inside the optic canal. We have done the anterior clinoidectomy, we have opened the optic canal, opened the falciform ligament, drilled the bone here, and this allowed us to remove this chunk of the tumor going inside the optic canal. This surgery is highly demanding. It needs good knowledge and good knowledge of the abnormal anatomy in addition to the normal anatomy. Okay. Here, another case where the tumor is attached to the stalk. And here it is attached to everything surrounding the optic nerve and the carotid artery. because you don't know where it's going to grow. These clinoidal meningiomas, they can grow anywhere they like. So the aim is to remove as much as you can. Again, here we free the stalk and you can see the posterior clinoid. Okay. Tumor being separated from the optic nerve and chiasm. And opening of the dura. Here is the optic nerve. You want to open the dura so that you can drill the anterior clinoid and remove any involved dura. Okay. Here is the drilling of the clinoid intradurally. And the last piece is the most difficult one, and it is the one that you have to be careful because it is sitting here on top of the carotid artery in the roof of the cavernous sinus. And you can see the blue color here of the venous plexus that's surrounding the clinoidal segment of the carotid. Here we remove the involved dura, we open the falciform ligament and the dura in the optic canal. Here you can see the third nerve at the edge of the territorial edge here. You can dissect the arachnoid and gain further entry. Again, here we have done the drilling of the anterior clinoid intradurally. We continue to do so until we open the optic canal and open the severe orbital fissure. If the case wasn't associated, here is the dural fold between frontal and temporal. And here is the drilling to open the severe orbital fissure completely. This case was one of the difficult cases, one of the cases that was really difficult, extensive anterior clinoidal meningioma extending into through the tentorial notch into the posterior fossa here. You can see here I'm separating the tumor from the middle cerebral artery, going into the carotid here. Again, you have to differentiate between the feeders of the tumor or the in-pass artery, carotid, middle cerebral, anterior cerebral. Here's the third nerve. So it was extending everywhere. It arrived here from the anterior clinoid, went medially, went posteriorly, went into the cavernous sinus, through the tentorial notch into the posterior fossa. This is the optic nerve here on the left side, working between the carotid and the optic nerve. Again, it looks formidable. You cannot remove it. Being patient, trying to find a good plane of cleavage, using the ultrasonic aspirator, carefully, of course. Here we're removing it from the anterior clinoid, dura of the anterior clinoid, which is the main feeder here. That's why you see a lot of bleeding. Again, carotid, anterior cerebral, middle cerebral, encasing, complete encasement. Can we do that? Yes, we can. Here is the posterior communicating. Let's try and strip it off the tumor. Let's see whether we can. Actually, we did at the end of the day remove it from there. Again, here working in various compartments. Whenever you feel disheartened in one compartment, you try your luck in another compartment. Carotid full extent. And you can see here the optic nerve, and you can see here the stalk, pituitary stalk. So nerve, stalk, carotid artery. So what is there? Here is the it looked formidable and not excisable at the beginning. But as I said, don't judge that before you go in. Have a good information, have a good vision of what you are going to find, and then give the patient his best chance. The first chance is the best chance. So again, the carotid was still communicating. We went into the posterior fossa following the tumor and removed it from there. This is the basilar artery here, its branches, the superior and the posterior cerebral. And you can see this is the posterior communicating going to the posterior cerebral artery. All right. Now, this is the last video, and I think we have finished in good time. We did not increase anything on over the 1 hour that we promised that we will finish. Again, here, frontal, temporal, stripping the dura of the greater wing of a sphenoid, drilling it until you reach to the anterior clinoid here. And you drill that extradurally, then you go in, drill it intradurally, and so on. Copious saline to avoid heat damage for any structure, and then going in. This is anterior clinoidal meningioma. I started with the temporal extension. This is here the lateral wall of the cavernous sinus. Remember, this is temporal, this is frontal, and we started here with the, I usually do so, start at the temporal part. Again, here you face the branches of the middle cerebral artery, some of them going into the tumor, some of them they are in pass. You have to differentiate. Here is the branch that's going into, again here, middle cerebral with its branches. What is the branch going into the tumor? What is the branch which is in pass? Careful, patient dissection. No matter what the time, whether it takes 10 hours or 16 hours or 22 hours, there's a job that you need to do, and you need to do it patiently. Here, removing part of the arachnoid, which is attached to the optic nerve here. We know the carotid is here. This is still cuff of the tumor around middle cerebral going into the carotid. Easy and slowly, you can actually strip it. Optic nerve. The carotid is here, anterior cerebral, middle cerebral. So obviously now we should come across the third nerve, which we'll see in a minute. So this is the third nerve. We are after every piece of the tumor, if we can. If we can't, we can't, but if we can, that's good. So carotid, and this is the middle cerebral, anterior cerebral is there, and still a cuff of a tumor here at the tentorial edge surrounding the posterior communicating artery. So you end with something like this: carotid, posterior communicating, middle cerebral, anterior cerebral, and so on. Okay, with this I finish, and I'm happy to take your comments and questions. Thank you for being with us.
Thank you so much, Professor. Your presentation was nice and sweet. So it's we are always grateful to have you as a mentor, and you are our inspiration and the role model.
Thank you.
So yeah, I will ask people to ask questions. Those who are not able to talk, they can post their questions on the chat. So Prof, I have one question.
Sure.
Two small questions for you before we go to others.
Sure.
The first one was, have you ever encountered a bilateral anterior clinoidal meningioma? And the second one, when do you repeat MRI scan in post-operative period? When do you do it?
Right. As far as the post-operative MRI, it is the following morning, whether I finished at 2 o'clock in the afternoon or 10 p.m. or early hours of the morning at 2 a.m. the MRI is at 7 a.m. the following morning. There is no reason to delay it, and there is nothing that can convince me that CT is the best for these cases. MRI has the upper hand even in terms of the detecting the bleed. So this excuse of doing CT post-operatively, I do not believe in it. I think anybody who does CT post-operatively does not want anybody to see the result of his work. So I insist on doing MRI, and I insist doing it the following morning. Bilateral anterior clinoidal meningioma, in this case, it has to be arising from the tuberculum celli going both sides. So you better speak about it as tuberculum celli meningioma rather than bilateral clinoidal meningioma.
Thank you so much, Professor. We have a question on the chat from Rania. He says, what about the retraction technique you use?
Retraction?
Retraction technique.
Simple. I don't keep continuous retraction. Sometimes you don't need retraction. The sucker will do the job for you. But sometimes you need a retraction. But always with retraction, you have to be aware of the damage that you may cause to the brain tissue, and don't keep that constant every now and then. You just release the retraction to give a good blood supply to the brain.
Thank you, Professor. Another question again from Rania. Is the from Adnan, say, what is the most frequent blood supply of anterior clinoidal meningiomas? And is there any need for pre-op embolization?
Right, the blood supply can come from any of the arteries around it, but the one that everybody accepts as the main blood supply coming from the ophthalmic artery directly or through the posterior clinoid. But as I showed, it can come from the middle meningeal, from the carotid directly, from the superior hypophyseal, from the posterior communicating. So it is rich in blood supply. How often did I need to do embolization? Just one case of the anterior clinoidal meningiomas. And I showed that case to you already. It was very vascular, it was huge. But generally, I do not like to do embolization unless I have to. Embolization is extra procedure, extra money, extra risk on the patient. So unless you really need it, do not do it.
Okay, Professor, one more question from the chat before we ask the participant to ask questions. Again, from Rania, is the superficial middle cerebral vein is the same called superficial Sivion vein? In
Yes.
Roton, you just called it superficial vein.
Yes, they are the same. Yes, absolutely. We differentiate between the deep system and the superficial system. And the superficial middle cerebral vein is part of the superficial venous drainage, away from the deep venous drainage. And it goes either back to the sagittal sinus, or goes to the sphenoparietal sinus, or go to the cavernous sinus.
Thank you, Professor. Now we are taking questions from participants. If you have a question, please raise your hand and feel free to ask questions. Okay, in the meantime, from the chat again, how to repair pneumatized clinoidal process from Satyanarayana.
Yeah, better not to open pneumatized anterior clinoidal process, but people have done this and they got CSF leak. They could recognize there and then that there is a hole in this anterior clinoid leading to the sphenoid sinus. And I cannot remember who is the author who described this pendulum technique, where he catches small piece of muscle and then he pulls it through into the defect in the anterior clinoid. But we know with just a piece of muscle, piece of fat, and the glue, then you can actually close it. If you discover this later on, then you can use lumbar drain. If it works well, if it doesn't, then you have to repair it either by endoscopy, transnasal, which is usually difficult, or reopening again.
Thank you. Any questions or comments from the participants?
Yes, Dr. Gabul, I believe Faraz Abdullah has a question. Go ahead, Faraz.
Okay.
I'm Dr. Faraz, a neurosurgeon from Erbil, Iraq. Thank you very much, Dr. Ibrahim, for this nice presentation. Your work is actually very impressive. My question is how to deal with bleeding from the major vessels during dissection of the tumor from the carotid or from the middle cerebral artery.
All right. I was fortunate. I had only one case where there was bleeding from the carotid artery, and I just repaired it immediately there and then. So I was lucky, really. But you have to close it. You just cannot put Surgicel and things on top of it. It will cause pseudoaneurysm and it will rupture again. So the best thing is to repair it immediately, and this happened with me once.
And you repair it with suture material,
Yes.
which type and which? Oh, okay. Thank you very much.
Pleasure.
Okay, Rupesh has a question. Go ahead, Rupesh.
Yes, hi. Hello, Professor. Thank you so much for this presentation again. I had a good time listening to you, as always. So my question is, for doing anterior clinoidectomy, how would you do it? Would you choose to do it intradurally or extradurally? Like, which one is better with less complications and more practical?
Actually, with all the cases of anterior clinoidal meningiomas, I'm speaking about not the early part of my experience, but once I got experience with these, I used the extradural and the intradural. I found that you can not completely remove the clinoidal process extradurally, so I do the best extradurally and then leave the last part for intradurally.
Thank you.
Okay, Prof, I have one more question.
Sure.
Yeah. In case you get CSF leak, do you also perform a lumbar drainage? If yes, what about if it persists? The patient is on lumbar drainage and it persists, what do you do?
As I said, depends on whether you discover that you have done opening into the sphenoid sinus or ethmoidal sinus, and then you do whatever you want to do there and then, plug it with muscle, with fat, with Surgicel, and with glue. If you don't discover it and you find the next day, the following day, there is CSF leak, then the best thing, the plan of action is to put the lumbar drain for 4 or 5 days. If that doesn't work, then you have to go and repair it endoscopically or reopening of your craniotomy.
Thank you, Professor. Any other questions or comment from the panel?
Dr. Ibrahim, a beautiful lecture. I'm Arturo Ayala from Mexico City. I saw your beautiful presentation.
Thank you.
And what is your advice about how long you need to remove the optic canal? We know the depends of the station of the tumor, but sometimes we can make a huge unroughing the compressions, like prevent the ischemic lesion in the optic. What is your advice about this?
Whenever we're dealing with the optic canal, we have to deal with the optic canal as males as you treat a female. It has to be done with delicacy, with patience. You have to know exactly what you are doing. Don't put the pressure by whatever drill or sonobet or the rongeur when you are using it. You have to know the anatomy well. And if you do that, then the chances of doing ischemic change to the optic is very, very little. You have to open the falciform ligament. You have to open the bony canal. You have to open the dural sheath around the optic nerve. And as I said, being patient and delicate, then there should be no ischemic problems.
Thanks so much, and congratulations again for your presentation. You've had a lot of experience about meningiomas, and this is outstanding outcomes. And thanks so much for this lecture.
It's my pleasure. Thank you very much.
Any other questions from the panel?
Okay, Dr. Kabula.
Professor Ibrahim is one of the giants of neurosurgery in the world. So we are so glad to have you as a teacher. You are making us better and more thoughtful persons. So you deserve a big thank you for all the sleepless night that you spent to prepare these presentations. Thank you so much, Professor.
It's my pleasure. Thank you very much.
Okay, thanks everyone for coming. And what's the topic next week, Dr. Sabir? Do you have a topic yet?
Because next Wednesday, I have to participate in the World Federation of Neurosurgical Society.
Oh, okay, so the following week.
So I'm part of the group that is presenting. I'm going to present about the microsurgery for colloid cysts. So I thought that, it will just interfere of having two lectures on the same day. So I'm not having my usual lecture. Next Wednesday, I'm having the meeting at 12 p.m.
Okay, we can televise that?
Yeah,
Oh, great.
I'm not responsible for it. Imad Kanaan is responsible. I can ask him.
Oh, okay. We'll talk about it later.
Sure.
Okay,
The other thing that, as you know, we are coming towards the Eid al-Adha, which is the major event in the Islamic world, in the Arab world. It's a holiday. So during that Eid, we will not be having any functions. I was thinking, and I talked to my colleagues in Turkey, and maybe on the 12th of August, we can do something together. Do you agree to that? So I can speak about surgery for parasagittal meningioma. They can speak about gamma knife for the parasagittal meningioma.
Okay, we'll talk about it and get the details later. Okay, thank you very much.
Thank you.
Bye-bye.